Good morning, and today's topic is about medical emergencies in dental practice. So, before that, I will request you to subscribe to my channel, Painfree Partha, and also visit my website www.painfreepartha.com. So, greetings from Mahatma Gandhi Medical College and Sri Balaji Vidyapeeth University. So, why should there be a topic like this? Why do we need a topic like this? So, because we should be prepared for it. A medical emergency in dental practice, we should be prepared for this. We should prevent this. And in case if it happens, we should identify and correct this. This may be okay for all emergencies, but this is essential for dental practice. So the incidence is 5 to 12%. What does it mean? If you are doing dental procedures, that means around 10 per day, you are getting one. Some sort of dental emergencies. I don't know whether this is textbook evidence. Reasonable big practitioners, they have not created evidence. So sometimes some evidence goes even up to 50%, even correcting minor things. So if you are doing 100 procedures in a month, you are likely to get minimum 5 medical emergencies. So what are these medical emergencies? It may be a vasovagal syncope. It may be a postural hypotension, maybe fits, hypoglycemia, wheezing, BP rise. So BP fall and BP rise. Intravascular drug administration, anaphylaxis. These are all the possible things where postural hypotension and syncope comes first. The whole list may be like this. CNS related disorders. You can see syncope and fits. You can see cardiovascular changes, postural hypotension. Hematological changes, bleeding. This is more of surgical emergency. Respiratory emergency, wheezing. Drug-related local anesthetic toxicity and anaphylaxis, adrenal and hypoglycemia, endocrine emergencies. So CNS, syncope, postural hypotension, asthma, local anesthetic toxicity, anaphylaxis, adrenal hypoglycemia. All these things are almost a near total list of medical emergencies in dental practice. So we should go from common to uncommon. What is common? I told vasovagal syncope, then postural hypotension. First, we describe what is vasovagal syncope. It's a sudden, it's not slow, it's a sudden, transient, it comes up back again, very temporary. Loss of consciousness due to cerebral hypoperfusion. The brain is not perfused enough with the blood, so it's a transient loss, it's a sudden loss of consciousness. They, yes, predisposing anxiety, fear, and pain can be a predisposing factor, while sitting upright position, hunger, hot, humid climate, there is no air conditioner. All these things are predisposing factors, even though sitting an upright position is a major thing or standing sometimes. By the way, what are the predisposing factors? Pain, fear, anxiety, non-AC, very hot, all these things. He has not taken food. All these things pushed together as factors which will increase the incidence of vasovagal syncope. Are we addressing these factors and preventing an emergency? Okay, this patient has come to, okay, have you taken food? Are you comfortable? All these things. Are you anxious? Is there any drug to give or something like that? All these things have to be addressed to decrease the incidence of vasovagal syndrome. When in doubt, do it supine like this. Position yourself for success. Do it supine yourself, because you need to have a recovery bed, because sometimes you do the procedure for so much time and then suddenly wakes up. So this is vasovagal syndrome. So sometimes this can also cause postural hypotension. Get the recovery bed. Please talking with the patient, because sometimes if he goes unconscious, we will not know. Hypotension with sitting or standing. This is classical. From supine, if he gets up, then it develops a BP fall, then it is called postural hypotension. Usually, within 10 seconds, our body will compensate and the BP will become normal. Tuck, tuck, it will become normal. If it doesn't become normal, then it is called postural hypotension. So remember, because if you lie down here, it is 8 millimeters and it goes down to minus 44 millimeters here. Intake of certain drugs, prolonged convalescence, inadequate reflex postural, late stage of pregnancy. All these things are prone for postural hypotension. Certain drugs, prolonged convalescence, he is having some malignancy, he is having stroke, he is not getting up and like this, he is not active, convalescent period. He has developed a corona and he is in a post-corona wheezing and all these things and he is ill, inadequate reflex. So we get lot of drugs for these prostate, Parkinson's and BP. So these drugs can interfere with this and cause postural hypotension. Okay, there are certain drugs which can cause. So why this is being pink underlined? Because all our dental patients will be having either of the three, because they are 65-year-olds, maybe prostate, they may be Parkinson or blood pressure. These we need to inquire about these drugs, whether we are getting for this drugs, the patient is getting for this, and then we should be aware of this. That is what is called prevention. So very simple is this, with the passive leg raising. You get him lie down and then raise the legs alone. This will get around 300 ml to the blood and giving him oxygen most of the times is normal. Very simple. Lie down flat. Make the patient lie down flat and raise the legs alone. This is called passive leg raising. Administer some oxygen. Most of the patients, postural hypotension will settle because you are auto-transfusing 300 ml of blood from the legs. But beware, the patient is fine. Put him back, then there is a danger. Put him back, then there is a danger. So beware, if everything is normal, when you are putting back into that position, check BP for some time and then make him sit. My opinion about these BP fluctuations in the current period are: one is these patients on antipsychotic drugs, another is gutka, and a lot of all these things they put into the inside the tongue or something like that, lot of drugs. So all these things can create BP fluctuation, restlessness during your procedure, because this fellow maybe around 18-20 years coming for a dental procedure, having this good can stop for 1 or 2 days, his fluctuations in BP and conscious status, restlessness can happen, and all these things will be blamed on your dental procedure and not good. Now we have what? We have vasovagal syncope and we have postural hypotension. What all we have to do? We have clear. Mostly do it in a supine position. All your risk factors have to be eliminated, and then beware, pace the patient supine and passive leg raising and oxygen. This is what we should be thinking in. Hypoglycemia is uncommon in non-diabetics. It's common in diabetics. That is what we should understand. A patient who is not a diabetic gets into 70, 65, everything, he will not go into symptomatic hypoglycemia. But diabetics, even if he goes to 90, sometimes if he is on 300, goes to 90, he may be symptomatic. Usually the dental surgeons ask for strict control, and any fall from 250 to 100 may be symptomatic. Okay, now I will tell you. So 1 week ago, you are saying, and you are telling, okay, sugar is uncontrolled, you go and come back. And then he comes back with a sugar of 100 and you do this. So from 250 to 100 within 1 or 2 days, he becomes, then you do your procedure and he becomes 80, he is symptomatic. So that is what is essential. CNS, CVS and ANS symptoms, check blood sugar. ANS, what is this? Autonomic nervous system. You may be having tears, you may be having sweating, all these things. Check blood sugar. CVS, hypertension is there in hypoglycemia. This is what we should remember. BP rise in hypoglycemia. Sugar falls, BP rise. This is the dictum. So CNS, yes, they may be having restlessness, nausea, vomiting, sweating. All these things point out to hypoglycemia. This is very common because the dental surgeon always instruct on 250. Immediately in 1 or 2 days, they should come to 100. Keep this. There is nothing wrong in this. Keep this by the side, which is working and which is filled with a good battery, and your strips, needles, because keeping this, we may not have needles, we may not have strips, and the strips has gone out of expiry. So all these things have gone. So we should keep a working glucometer by the side, one or even maybe two, and keep sugars like this. We can also keep an hypotab dextrose chewable tablet in the dental clinic. So this is about hypoglycemia. We have ANS symptoms, hypertension. There may be sweating. So beware, sometimes it may be even 100, 90. This is symptomatic hypoglycemia. Give dextrose tablet. And nothing wrong if 100 goes to 140. But something is wrong if 100 goes to 60. That is where we should be aware of it. Even if it 150 goes to 190, it doesn't bother much. So you can always keep an adrenal ampule in the clinic along with a syringe. Rapidly evolving multi-airway, pulmonary, gastrointestinal, cardiovascular systems. Give adrenal half cc IM and remove the offending agent. We are trying to give ketorolac or something like that. Try to remove this if possible. Keep the drugs and see the expiry date. For example, your adrenaline is kept at the time of your inauguration of your dental clinic. After that, you are not checked. So that is what we should know. Epileptic seizures. So there is a peculiar thing about anaphylaxis. I'm telling you, there are serious symptoms, there are respiratory symptoms, there are upper respiratory symptoms. All these things, there is maybe tidal, wheezing, BP may fall. All these things has got one answer, that is adrenaline. Don't give nebulization, don't give steroids, all these things are secondary. If you have diagnosed adrenaline, at least give IM half cc or quarter cc adrenaline, at least you are safe before shifting. So this is about epileptic seizures. A non-epileptic gets fits. We can give midazolam 5 milligrams sublingual. We should ask the history of drugs. He will not tell because he will be taking a carbamazepine 200 milligram HS for fits for 3 years, and he will not reveal it to the dental surgeon because he may think that it is not needed like. So opinions may not be. You have got a good neurologic opinion, physician opinion. He has written something. Continue the drugs or all these things. Who is going to help you when the patient throws fits? Nobody is going to help you. Yes, opinions we can take for legal things, but who is going to help you? Yes, give a midazolam 5 milligrams. The ampules are available. Give an ampule. Lie down. Give oxygen. Take a pulse, BP. All these things. You are in through for a safe recovery of a patient. Sometimes an intravascular injection of a local anesthetics can cause fits. So asthma, a non-asthmatic, drugs, inhalers, you auscultate for wheezing. You keep steroids, oxygen, and nebulizer. If you are doubtful, if a non-asthmatic is there, keep him in the pre-procedural room and give him good nebulization with two drugs of levosalbutamol and budesonide, two drugs combination, and then nebulize for 15 minutes. Let him be stable, take a pulse oximeter, and ask him to come and do a dental procedure. There is nothing wrong in this. Keep this in the procedural room or pre-procedural OPD for your safety. Cardiac emergencies and stroke. These are all extremely rare. The patient or doing a dental procedure, he gets a stroke, is extremely rare. But rhythm disturbance can happen, intravascular adrenaline can go, aspirate slowly before injecting because all dental surgeons play in a field, give injections, local anesthetic in a field where it is extremely vascular field. A lot of vessels, nerves, arteries, veins are so close that it is likely it may go into. It is not that we have to give inject 10 ml. I got given 1 ml of local anesthetic into the supraclavicular space here and then got fits. That 1 ml, 1.5 ml has gone directly into the suprascapular vein. So it's not like that 100 ml or 50 ml has to go. Sometimes you aspirate and give. Don't do fast aspiration. Give a slow aspiration because you are inside the vein, but a fast aspiration will collapse the vein and we may not be able to aspirate blood. So it will defeat the purpose. So a fast aspiration will collapse the vein. Adrenal crisis. Many patients are on steroids, even some ointment. In these patients, give hydrocortisone 100 milligram shot before extraction. Don't worry about infections. Sometimes there may be steroids, eczema, so many years. These patients also check BP. Then you give hydrocortisone 100 milligram IM shot. Then you do a dental procedures. Hyperventilation, they will breathe like this. Just keep the patient in a comfort zone. We can have these things: take a Venflon, plaster, syringe, 100 ml saline to flush it, or distilled water to flush it, an IV fluids, or a dextrose normal saline, or ringer lactate, whatever it is. Yes, we can keep all these things in the OPD. Adrenaline, atropine, ephedrine, glucose, IV fluids, nitroglycerin is not needed, ondansetron, salbutamol, steroids, both nebulized and IV. Yes, we need to have a history. We need to have an LMP and pregnancy. Check the pulse, blood pressure, stethoscope, investigations, and records. Put the records. Take him the records. There is no urgency. There is no 1 hour, 2 hours. He may be having a record of some hospital, Tiruchi corporate stenting done, or some fits done, or a neurosurgery done in a Bangalore hospital. All these things ask him to bring and see before doing the procedure. You should have oxygen connecting tubes, cylinder opening spanners. There is no big funda in having oxygen cylinder. The oxygen spanner should be nearby and a person should be able to know how to open the cylinder and how to start oxygen. This is very important. IV set and cannula, emergency drugs, and an ambu bag for starting a ventilation. Ambu bag and oxygen, and sometimes yes, because we can have two monitors like this. Nowadays monitors have come very cheap. You can connect your pulse oximeter and a BP when you are doing a dental extraction, and in the dental procedure, post procedure room, you connect the monitor for some time and then ask the patient to go home. This is not very difficult. You can have 2-3 monitors into a dental procedure room. Laryngeal mask airway, I prefer to keep 3 and 4 size. 3 is for female and 4. You don't need to know anesthesia, airway, anything like that. You deflate the cuff like this, take an MLR syringe and deflate the cuff and insert like this. Automatically it will go and do an ambu bag like this. Essential to know that this is laryngeal mask airway. We can easily put and not much of intellectual knowledge is needed to do this and create or an artificial airway. Sometimes we need to use this instrument. Many times we are not using this instrument. Put a stethoscope, check BP. Always keep the number of the ambulance in a big board and nearest to hospital contact. You may be having contact with an hospital which is 5 kilometers or 10 kilometers. You are admitting there, your friends are, but always keep hospital contact which is nearby. Don't make him the enemies, because if you are doing a procedure, he becomes unconscious. Shift immediately after giving oxygen IV fluids to the hospital which is nearby. You cannot, because your hospital or your relative hospital is 15 kilometers away. It is not needed. You don't develop enmity with your hospital, which is very close, less than a kilometer. Some self questions. Do you know cardiopulmonary resuscitation? Do you know to connect monitors and pressure PP? Do you know how to administer oxygen? Can you put a step and understand what is wheezing, crepitations? Can you take an IV line? Because many doctors even have forgotten how to take an IV line, or else you have to keep a trained personnel for basic report. Have you taken your food? That is very important. Have you taken your food? Because many times people skip food, practice busy. They don't. Nothing like that. There is nothing busy. You take your breakfast and come start your clinic. And 11:30 you give a gap from the home or from outside. Take some fruits and have a maybe sugarless juice or a black tea or a green tea or a normal tea. Then go back again to start your work. 1:30 2 p.m. you take the lunch. There is nothing wrong in this. Don't postpone the lunch just because 3 4 patients are there. Get the lunch to your clinic. Wait, let the patients wait for extra 10 minutes. Take the lunch. Finish 2 more cases and then go home. So don't panic. Be relaxed. Because if you panic, your thinking process may be difficult. Attitude and preparedness. This is what is important. You should have a team with skilled staff and commitments and equipment. We should have equipment. We should have ambu bag. We should have oxygen cylinder. We should have spanner to open the oxygen cylinder. Or we should have full oxygen cylinder. Sometimes we may need to have two. At least we can have one oxygen cylinder, one oxygen concentrator for an emergency. To switch on the current, oxygen will come. Action. What to do is vasovagal syncope. What to do? Postural hypotension, what to do? Fits, what to do? Asthma, what to do? Local anesthetic toxicity. All these things we can do if we have some basic understanding of the fundamentals and become more professional in our practice. Thank you very much for patient listening. My slides are available in painfreepartha.com and channel is Painfree Partha.